Hello, and welcome to PodMedics. My name is Kat, and I'm currently a junior doctor in respiratory medicine at West Middlesex Hospital in London. So this podcast is about non-invasive ventilation. I'll be talking about the principles of non-invasive ventilation, which is often not taught very much at medical school, but is useful to know about, particularly when you start out as a junior doctor. Ventilation is the exchange of air between the lungs and the atmosphere, and it can be achieved artificially in two ways, invasively and non-invasively. Invasive ventilation is where ventilatory support is achieved by bypassing the upper airway, hence the reason it's called invasive. Examples you may come across, particularly in theatre, are the endotracheal tube, the laryngeal airway, or in an ITU setting as a tracheostomy. Non-invasive ventilation is where ventilatory support is achieved through the patient's upper airway, using either a face mask or a nasal mask. A face mask is most commonly used, as most patients are mouth breathers. The most important types of non-invasive ventilation you'll need to know about are CPAP and BiPAP. So CPAP, which stands for Continuous Positive Airway Pressure, was first introduced in the 1980s as therapy for obstructive sleep apnea to prevent pharyngeal collapse. In CPAP, a positive airway pressure throughout all phases of ventilation, so inspiration and expiration, is applied. This raises the mean airway pressure within the lungs to keep airways open, prevent airway collapse, and even ventilate collapsed areas of lung. It is therefore most useful for oxygenation in type 1 respiratory failure, where the PO2 is less than 8, but the PCO2 is normal or low. CPAP also has cardiovascular effects. It improves left ventricular function by reducing afterload as CPAP increases intrathoracic pressure, which has a squeezing effect on the heart. This is why it is of particular use in acute cardiogenic pulmonary edema. Meta-analysis shows that the use of CPAP in cardiogenic pulmonary edema reduces the need for tracheal intubation. In bi-level positive airway pressure, the ventilator cycles between two pressure levels triggered by the patient's own breathing, and they are known as the IPAP, the inspiratory positive airway pressure, and the EPAP, the expiratory positive airway pressure. Ventilation is produced by the IPAP, while the EPAP recruits underventilated lung in the same way that CPAP works. Therefore, BiPAP not only improves oxygenation, but also the patient's tidal volumes and carbon dioxide elimination, and this is particularly useful in type 2 respiratory failure. BiPAP is most commonly used in acute exacerbations of COPD, where a patient has a respiratory acidosis with a pH of less than 7.35. This graph demonstrates the difference between BiPAP and CPAP in their ventilation settings. BiPAP, represented by the red line, has two distinct airway pressures, the higher IPAP during inspiration and the lower EPAP during expiration. CPAP, however, shown in green, has one constant pressure throughout both inspiration and expiration. So a general rule for the use of non-invasive ventilation. If a patient is in type 1 respiratory failure, consider the use of CPAP. If a patient is in type 2 respiratory failure, consider the use of BiPAP. The most common conditions that require NIV that you'll need to know about are COPD, respiratory failure, weaning off invasive ventilation, acute cardiogenic pulmonary edema, and obstructive sleep apnea. You're more likely to come across BiPAP being used in hospital. BiPAP is used both in chronic and acute cases of COPD. There's a large body of evidence that supports the use of BiPAP in acute exacerbations of COPD, reducing intubation rates and mortality, particularly in acidosis. This is often associated with type 2 respiratory failure, where the pCO2 is more than 6 and the PO2 is less than 8. Other causes of respiratory failure, such as pneumonia, atelectasis post-surgery, thoracic abnormalities, for example kyphoscoliosis, and neuromuscular disorders such as myasthenia gravis and Guillain-Barré syndrome also benefit from the use of NIV. BiPAP is also used in weaning patients off invasive ventilation. CPAP, which is less commonly used, is used in acute cardiogenic pulmonary edema refractory to maximal medical management and obstructive sleep apnea. Contra-indications. Patients sometimes find NIV claustrophobic and uncomfortable, and they end up fighting with the ventilator rather than working with it. For this reason, they tire and become non-compliant, or they may even refuse to wear the mask in the first place. NIV is not suitable for use if the patient has impaired conscious level and are unable to protect their airway, i.e., they have an unsafe swallow and a poor cough reflex. NIV is unsafe here as the patient may develop an aspiration pneumonia. Copious secretions, vomiting, hemodynamic instability, and severe hypoxemia for similar reasons are also contraindicated. Recent facial or upper airway surgery, facial burns, and trauma are contraindications for the use, as the tight-fitting mask can cause further damage, necrosis, and pressure sores. The positive airway pressures can cause gastric distension, and for this reason, NIV is not used where there has been recent gastrointestinal surgery or bowel obstruction. So the complications of non-invasive ventilation include gastric distension, which is due to positive airway pressure pushing air into the stomach, pressure sores from ill-fitting masks, pneumothoraces, and ventilator dependence. Using NIV. Firstly, to use NIV, consent must be gained by the patient. The right type of mask and mask size needs to be chosen so that it fits well, so that it's not too loose to cause a significant leak, and it's not too tight, so that the development of pressure sores or necrosis doesn't occur. The patient's oxygen saturation must be monitored, and oxygen should be administered if the saturations are less than 85%. An arterial blood gas should be repeated in an hour to see whether there has been any improvement in ventilation, and settings may be adjusted accordingly based on this. So that's it on this podcast on non-invasive ventilation, and thank you for listening.